Hello, everyone, and welcome to the Behavioral Health Echo series. Thank you for being here. This is a training brought to you by the Center for Substance Use Training and Telementoring, CSTAT, a division of the Be Well Institute here at the University of Texas, San Antonio. My name is Andrea, and I will be helping to facilitate this conversation during the next hour. Before we start, I want to remind you that this session is being recorded for later distribution, and you will find it later at our Be Well Texas YouTube page. To help us with attendance, please continue adding your names, email addresses, and affiliations on the chat. We will need this information, especially if you're seeking CEUs after this session. That information will not appear on the recordings. And today we have Elisa Medellin, one of our hub experts, presenting on effective responses for trauma and crisis. After that, we're opening the floor for your questions. And then, as usual, someone from our community of learners will discuss a brief case with us. We invite all of you to take part in this conversation. Please remember, echoes are the space of all teach and all learned. So your takes and your perspectives are not just welcomed, but are a very important part of this training. So please unmute yourselves and take part on the conversation. And we're going to start now with some introductions from the hub. From California, Didi, welcome to Behavioral Health Echo.
Thanks, Andrea. Good morning, everybody. It's morning for me. I'm Didi Stout, and oops, I've got to say okay to the recording. Okay, let me get that off. And I'm here in Emeryville, California, the home of Pixar Studios and a few other interesting bio systems. We do a lot of that work here. I am in private practice here in Emeryville, California, seeing individuals, couples, and a lot of families these days, working in a harm reduction psychotherapy basis. I am also on faculty at a few places in the Bay Area, the Wright Institute, University of San Francisco, and St. Mary's College, all of which where I teach in substance use disorder courses for graduate students for the next generation of therapists. Thanks.
Thank you, Didi. Nice to see you.
Nice to see you.
Welcome to Behavioral Health.
Oh, hello, everybody. I'm Leslie Manson. I'm a licensed clinical psychologist, director of implementation science and training, and a clinical associate professor at Arizona State University. And I do a significant amount of consultation internationally for building fiscally sustainable behavioral health programs. And I will note something that Didi left off. She's also an expert in MI, which always comes in handy here within the ECHO too.
Yes.
So just because I know we'll probably turn to that later today too. So thank you.
All right. Thank you, Leslie. Joseph de la Cruz, our case presenter. Do you want to briefly introduce yourself, Joseph?
Yes, thank you for having me. My name is Joseph de la Cruz. I am a program director for the Aliviana Recovery Support Services program here in El Paso, Texas. I will be presenting in a bit once you guys give me the opportunity, but any other questions? Anything else I should say?
Okay, thank you. That's fine. We'll go to you in the second part of the session.
Thank you.
You're welcome. No, thank you for presenting a case for us. Elisa, I think that we could start sharing your didactics. And in the meantime, if you want to briefly introduce yourself and your role in your organization. Thank you.
I'll do. Let me go ahead and share my screen. Quick. Alrighty, there you guys go. Can everybody see that?
Yes, we see it. Perfect.
Lovely. Well, my name is Elisa Medellin, and I am part of the Strong Star community. We work with veterans who are struggling with PTSD. I'm also part of the Strong Star Training Consortium, who helps train clinicians in evidence-based treatments for PTSD, specifically with veterans. Today, I want to talk a little bit about how we're going to bridge trauma and crisis, and things that we can do when we do have clients in crisis. I encourage you guys, please participate. Feel free to throw questions in the chat. I really like interacting with people. Let's get started. So I don't have any disclosures other than these are, of course, are my personal views, but I'm not important enough to have anything else to disclose other than that. Learning objectives. Okay, so today we're going to be explaining the connection between trauma and crises, and describe the role of suicidal ideation and behaviors, and as well as assessing individuals for suicidal ideation behaviors, and what we're going to do to effectively respond to people who are in crisis. Okay, let's talk a little bit about these connections here between trauma and behaviors that we might see in people that we work with. So 70% of people in the world have experienced a traumatic event in their life, with 5.6 developing PTSD and 3.9% of that population experiencing PTSD in their lifetime. I understand that some of you guys might work with youth, so I thought this was an interesting tidbit that over 80% of youth in the juvenile justice system have reported experiencing a trauma or multiple traumas. And then in comparison to other psychiatric conditions, PTSD is more significantly associated with suicidal ideations and attempts. And then lastly, exposure to trauma increases that risk for suicide. So I guess, how many of you guys, and you can either do like a thumbs up or throw it in the chat, work with a population that is at high risk for trauma? Yeah. Mm-hmm. Mm-hmm. Yep. Yep. And how many of you guys work with clients currently that have expressed, or even in the past, have expressed suicidal ideations, suicide attempts, or behaviors? Yeah. Okay. And so we're all pretty familiar with what that might appear like, right? So we might ask ourselves, well, why does this relate? And if you notice that on the left-hand side, you'll see avoidance-based strategies in PTSD. So one of the symptoms, right, of PTSD is avoidance. Avoidance of maybe that particular trauma or things that remind them of the trauma. But this is going to look different for different people, right? So this might be avoiding particular people, places, things, but it can also be avoiding by engaging in some of these other behaviors with suicide attempt or suicidal behaviors or gestures as being a way of avoiding, and also a way of regulating, right? That sounds a little weird, right? That we're saying like, what? You know, people are going to be engaging in these behaviors as a way of regulating. We're going to delve into that a little bit more here in a bit, but helping really to regulate those intrusions, regulate that arousal and those cognitive fluctuations and emotions that are coming up when they're experiencing those symptoms of PTSD. And so that suicidal ideation and behaviors, they really are an attempt to regulate those challenges of problem solving, that emotion regulation, and that cognitive appraisal. Okay. What if you guys, and again, you can either take yourself off mic, you can throw it in the chat, but what if you guys heard people say about why they've attempted suicide or behaved in a way with suicidal gestures? What are some things you've heard people say as to why they've made this attempt? I can't do this anymore. Yeah?
To make the voices stop.
To make the voices stop. So to stop something. They feel hopeless. Mm-hmm. What's the point? So giving up altogether, right? To stop their pain. Yeah. So these are all pretty common explanations, right? When we look at this, we see that most people have put thought into this already. Oftentimes, people might come into our offices, into our clinics, and they might be expressing these thoughts, these behaviors. but might not be the first time they've experienced them. And one of the most important things that we need to ask is, well, why, right? What was the motivation behind it? And the reason why I want to know the why is because this is going to help me with treatment planning later. When you look at this little diagram here, you're going to see that you have reinforcements, right? The positive, the negative. You're also going to have those automatic, so internal things, and then social, those external things. And really, you'll see here in the positive, they're adding something that's desirable, right? I know somebody put in here to stop their pain, right? And on the other end of the spectrum, sometimes people say just to feel something, right? Sometimes I just want to feel something. I feel numb, or even gaining something from this, whether it be helping their way to communicate, right, what they might need. It might not be the most effective way of communicating, but it is nonetheless a way of communicating to others what is needed or what they feel that they need. On the negative side, it might be reducing that tension or reducing that negative affect. And then lastly, escape, right? Escaping interpersonal tasks or demands, avoiding something. But ultimately, what this all boils down to is that these things really reduce tension and negative affect, and they're all used to reduce suffering. When we look at the left side, this is considered the suicidal mode. So we look at the left side, that's what we consider when somebody's in a not stressed state, okay? So what this side over here on the left is what a person looks like when they're not stressed. So what their level of emotional regulation and cognitive flexibility skills are prior to a stressor. I like to think of this as, I'm not sure if any of y'all are familiar with DBT. When you think about that emotion regulation and the cognitive flexibility, right? Thinking about the Tasmanian devil, right? The whirling all out of control, and then Spock from Star Trek, right? Completely logical. And when somebody is in a balanced state, it's that equal balance between both. And so again, this is somebody's functioning prior to experiencing the stressor. But then somebody experiences a stressor, and they might be sent into that crisis mode where all four of these factors are interacting. And now this was identified back in the 60s by Beck. And you'll see that once one of these things is affected, oftentimes they're all going to be affected. And you're going to get those cognitive distortions coming up, right? Like, this is hopeless, I'm hopeless, I'm a burden, nothing's ever get better. And of course, that emotional component of depression and guilt, anger, often anger geared towards the self. And then you might also see behaviors. And these behaviors are going to be things that we see, like that social withdrawal, that isolation, maybe even substance use, suicide attempts, suicidal gestures, and then that physical piece where we talk about that agitation or even a lack of sleep or pain. So think about yourself, just take a moment to think about yourself, about how you react when you experience something upsetting, right? And kind of see how, and I won't ask anybody these questions, but take a moment to reflect on how your thinking changes, how your emotions change, right? And how your behaviors might change. And when we're listening to people as they're telling us this, we want to listen for the intersection of these things. What gets their crisis mode activated? What are their triggers? Sometimes people, when they're in crisis afterwards, it's hard for them to identify what happened. Like, how did I get from point A to point B? All I know is that now I'm in the hospital. Or I know in the past when I've made an attempt, this is something that triggered me. But there are times where people come in and they have yet to slow down and reflect on what those triggers were that led to this dysregulation. So we want to know, we want to assess. We want to assess for suicide risk, not just in the beginning of treatment, not just at the end of session, but throughout our treatment with our client, right? So as we're in session with them, as we're, and I say session loosely, this could be anybody. This could be the nurse that's doing their vitals. It could be their prescriber that's sitting with them throughout their session. It could be a peer coordinator that's working with them. But the assessment process doesn't just start and end at the beginning or at the end of the meeting time. It's done throughout the interaction with that person. I imagine that many of you guys already have agency practices in place. And of course, we want to be respectful towards those and continue doing those practices that your organization is urging you to use. You can also use suicide cognition scales that might be helpful in assessing, or you can even use the depressive symptom inventory suicidality subscale. These are assessments that you can find that'll help you get a better understanding of where someone might be. But really, I think one of the most important assessments you can do is a narrative assessment. So being able to talk to someone, engage with them, learn about them, tell me what happened, what was going on, with using your own clinical judgment, using your own personal skills, being able to have a conversation with someone. And I think sometimes we might get bogged down in, well, let me get that assessment out, or let me call the professional to be able to come over here. But really simply having a conversation with someone can really do quite a bit, as long as we're empathetic, we get our information, and we're reflecting what we're understanding. So my favorite is the narrative assessment. Not saying that these other assessments aren't helpful. They are wonderful and they are helpful. And we have a tool with us that we have with us all the time, and that is our voice. So one of the things that we can use with clients who have engaged in suicidal behaviors or engaging in any kind of suicidal ideation or have had a suicide attempt is by doing a crisis response plan. How many of y'all here have heard of a crisis response plan? Yeah, okay. So crisis response plans, they're actually shown to reduce suicide attempts by 50% or more. Some research actually even says 76%, I think was what some of the other research that I had pulled, but quite a bit. Yes, up to 76%. I mean, that's a lot to help someone reduce their suicide attempts. It also leads to fast reduction in suicidal ideation, and it's more effective than the traditional crisis management interventions, which is amazing that we even have this tool that we can use with us anytime, anywhere. Now, the important thing to remember about this crisis response plan is that it's done collaboratively. So this is something that's going to be done with your person that you're working with as a team. And I really enjoy that, because really they're going to be the expert on all the things that we're going to end up putting on this card. So the crisis response plan is you're going to have a index card or a piece of paper, or even a picture of this piece of paper, or on their phone, anywhere that the person can easily access it and have access to this information 24/7. I like to get an index card and then do it with them in session. But we're going to explain the rationale for the crisis response plan. And the rationale is basically that when they begin to experience their warning signs, when they begin to experience what might lead to a suicidal gesture or ideation, they can pull out this card and utilize the skills on it. And this card is a living document. So it's actually something that's going to be changing throughout time. We're going to want to be checking in with them throughout our time working with them and see if there's anything on there that we need to address or change. And again, this is going to be done in a narrative form. So what this might look like is somebody coming into your office after they've experienced a suicide attempt, and you asking questions like, tell me a little bit more about what was happening that day. Walk me through it. And so they're going to be telling you the story, right, of what was going on prior, what they were experiencing prior to the attempt, what was going on in their environment, what they were thinking, what they were feeling. And these are going to be able to help them identify their warning signs. What was going on in your body? Well, I was feeling really hot. I was beginning to feel overwhelmed. I was beginning to think that there was no point in living. Okay, great. Let's go ahead and write those down. Those are going to be their warning signs. And then we're also going to help them identify self-management strategies. And self-management strategies are going to be things that they can do on their own 24/7 without the assistance of anyone else. And this might look like things like reading a chapter from their book. This might be something like running for 10 minutes on their treadmill. This might be something like watching a 30-minute episode of their favorite show. Now, if you notice, I don't just say reading a book or watching their show, but it's something specific, right? So we want it to be as specific as possible and something they can do independently of anyone else. And something that we already maybe have a history that it works for them, right? Again, this is not my card. This is their card. So this is going to be personalized for that person. And the next thing we're going to do is going to identify reasons for living. Now, everybody's going to have different reasons for living, right? It might be their children. It might be their pet. It might be their job. It might be their religion. I don't know. It's going to be individualized to everyone. And it's going to be important that we help them identify those reasons that they keep going. What stopped them? What are those things that they think about now that they're grateful for, that they still have around? And then number 6 is going to be identifying social supports. So what are those supports that they have that also help support them? So are those people, are those friends? Are they friends online? Are they, is it their church congregation? Is it a family member? What are those social supports? Now, and also be ready to think outside the box, right? It might not be a social support that maybe we're accustomed to. So just being able to help, which is also why it's so important that when you do this narrative, you're getting to know the person for the person that they are, right? And then lastly, being able to provide crisis or emergency steps. So what are those last steps? After I've experienced a crisis, I see my warning signs. I'm working through each of these. I'm going to use my self-management skills. Okay, that didn't help me very much. Let me review my reasons for living. Okay, that didn't help me so much. Let me reach out to a social support where, mind you, I'm going to have their phone number on there for me to access as needed. And now I'm not feeling well. I know I might do something. I might act on these urges to kill myself. And so we always want to provide that crisis emergency step. What does that look like? Is that them calling 911? Is that calling the crisis line? Is that going to be calling the National Suicide Prevention Line? And at the very end, we're going to ask them to review this card, right? They're in agreement of it. And then we're going to ask them to rate how likely are they to use this card. And if it's anything below 70, then we're going to be like, okay, 70%, you're likely to use it, but anything below that, what's preventing them from using it? What do we need to change? How can we alter this card in a way that's a little more beneficial for them? And here's an example of what a crisis response plan card would look like. And you'll see that person's labeled their warning signs. They've identified things they can do alone. Notice that phone number there of their support actually has the phone number, right? We want them to actually write down that phone number because in the time of crisis, it's going to be hard to get the phone and get to the contacts and remember who you're reaching out to. And we're always going to be updating this as needed. Again, this is something they're going to have with them either in their pocket, in their purse, or on their phone. Again, it's going to be something easy for them to access, and it's going to be a living document. So we're going to review it every time to make sure that it has any updates that need to be made. And we also want to be sure they're using it, right? So when we're checking in with them, making sure that they are using their resource. And if not, what prevented them from using it? What do we need to do to update it? Oh, right. And then, of course, this was just a brief little overview of what crisis response plan is, and very brief overview on how to build one. But should you be interested in actually taking a webinar to learn more in detail, that information is here under that crisis response planning workshop. And there's also lethal means safety workshops. And that one's more geared towards people who have weapons in their homes, such as guns. And these are my references. And that's all I have for you guys today.
Thank you, Elisa. That's a lot of good information there. Let's hear some questions from the group or comments.
Okay, there you go. I don't have a question, but a comment. This very, very helpful, very, very explains a lot when it comes to the behavioral health part, the mental health part. And one of the things that I saw that I honestly had never seen was that crisis card. I had never seen that before. And that's actually a really good idea, and that's a really good thing. And as a person that also struggles with mental health as well, I did take a lot of this from your training to self-reflect. So I thank you for that. But very, very good. I appreciate you.
I'm glad you found it helpful. Joseph, thank you for sharing that. And it also reminds me, if you guys have time, try to make one for yourselves as well, so you can see what it's like to be on the other side, to have to think about, hold on, what would my warning signs be? What are my supports? So you can share that experience, as well, what it's like to fill out one of those cards.
And I actually thought about it right away. As soon as I saw it, I put myself right away where I saw him, where it says the vacation and I think the beach, call Jennifer, call doctor. I'm like, who would I put there? What would I think of? And I'm already looking at it on my end. So I'm gonna try it. That's something I'd try it, honestly.
Thank you, Joseph. Dee, please go ahead.
Thank you so much, Elisa. It was terrific. And there were two things that I wanted to comment on. One was I just read a study that looked at the suicide contracts that we used to make all the time and how unhelpful they are, which we used to say that back in the day anyway, but we had to do it for liability purposes. And, so everybody would card it out. And these remind me very much the cards of the relapse prevention cards that I used to make when that was my focus with folks. And we would do, on one side would be sort of the ways that people were triggered. And then on the other side would be, some solutions, if you will, or ways to manage those triggers. So I love using that in this format. Thanks.
Thank you. Leslie, you want to say something about suicide contracts here?
Oh, sure. Yeah. I mean, I definitely agree with what Dee just said, and we all were trained on that many years ago. It's now officially malpractice. So we no longer use those at all. I do also I'm a master trainer for suicide prevention intervention and obviously for CRPs. And I will also note the CRP language also is research-based, that more individuals prefer CRP for safety plan. So it's something to consider even as a language change when you're, working with either your friends, your family, colleagues, and of course with patients and, other communities. I do want to also note it has been effective, whether it's something that the person develops themselves, whether someone is doing it with them, like a peer approach, or whether it is a professional doing it, that up to 76% effectiveness. And that's reducing thoughts and behaviors for up to 6 months. So it is really important to note that it's actually built into video games now. It's built into social media. It's also built into the DoD and the VA apps, as well as other apps that people can have and download. So just kind of noting that it is what we are required to do for any licensed professionals. This is our requirement, period, for suicide intervention. And be cautious of some of the other safety plans that are entitled that out there. Some safety plans are CRPs. They just use, the safety plan language. Ensure you review it to make sure it has exactly those categories as Elisa was showing you. And you need to do it in order. The effectiveness is done by top down, so you don't want to go out of order when you do that as well. And so just make sure you do have one that is in that way. So be cautious of, say, some other ones like the Stanley Brown, other ones that are there. They are still helpful, but they do not have the level of effectiveness because they are not the same. The reasons for living is so important because that alone deactivates what we call the suicidal mode. And so that point is so important to have, and that's what's missing on most other safety plans. That's the difference when you look at those other ones. So, perhaps just download them. They're all free, download them, grab them so that you have them, so you can be able to use it. And the only other thing I will say is, as exactly what Elisa just said, is we do always say everyone should do this. We know the suicidal mode turns on when your stress levels are here and your actual specific problem solving and coping strategies are here. Okay, so when it goes above, none of us plan to experience suicidal thoughts and behaviors. They happen. So creating a crisis response plan for yourself is really important. In fact, I've had schools that I've worked with here in the United States that mandatory did that for the entire school from preschool all the way up in the district to high school. They had every single student create one, and they call it a student success plan. And what they did is they then practiced it every quarter related to different exams and other things so that they had a way to be able to self-monitor and be able to know who their helpers are, different types of coping strategies, etc. So there's a lot of ways you could do it. And I do encourage people, if you're in any type of a practice, providing group or peer support, create this for everyone, regardless if their suicidal mode, they've ever experienced it or if it's turned on or not. Create it. That's the only way we know that we can actually change the curve related to death by suicide. So just kind of putting that, shout out related to it. And I'm happy. I do have some crisis response plans. I can put them, the cards that you can literally just print and then cut and use. I can put them into the chat box if you'd like, if people want to just download some. And then there's pens you can get with a CRP on it, and they just go right back into the pen. There's a lot of fun things you can also find and get regarding that. So, okay, I'll be quiet now. Obviously, I can stand on a box and talk about that.
Thank you
So
so
glad you brought it
much for saying all that. Leslie, definitely, if you can share with us some of those resources that you're talking about on the chat, whether they are websites or places where people can, with some of our participants can train, or websites where they can find resources, that'll be great. So I think we're going to go to Lindsay, and then we're going to be moving to our announcements. Lindsay, go ahead, please.
Yeah, so I was just going to say that it sounds a lot like the RAP plans, Wellness Recovery Action Plans, done by the company we've been helping people with for years. I think the difference that I noticed is one of the extensions to the RAP plans is that it also has you write down, if you are going to the hospital, what services you want, what your preferences for hospitals are, where, who can pay your bills if you're in a hospital, things like that. So it goes into that kind of even further planning in case that crisis does happen. It also is serves as a medical, what is that called? It's like an advanced directive, but for medical, it's, so they have to follow it if you get it, assigned, notarized.
Thank you, Lindsay, and nice to see you again, as always. I also see here that Leslie's adding power of attorney there. Okay, so a lot of good ideas. Let's move for now to the announcements, and then we might go back to some of these resources when we discuss our case. So, Julio, if you can see the announcements, please. Thank you. And please remember, if you want to receive CEUs for today's session, just make sure that you answer the post-session survey, and please answer yes to the question related to CEUs. Your certificate of completion will be sent to you 2 weeks after today's session. Next. And if you or someone in your team has an interesting case, or any case for that matter, that you want to discuss with us, we make it really easy. We'll provide a form. Just send us an email at cstep@utesca.edu. Next. And please remember that the Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance for a variety of substance use needs. This is a free service, and we do have short form on the website that we're sharing with you. And once you complete that, someone will reply and will be more than happy to provide with the helps that you need. So again, that's the technical assistance free service that we offer here at CSTAT. Next. And please remember that, maybe this is something that's really, really cool, and I'm very excited about this. We're having a webinar. The webinar is organized by the Center for Substance Use Training and Telementoring in collaboration with PRIN, with the Peer Recovery Innovation Network, and we would love to see you there. The first session is on December 12th, and we're going to have Lauren Gilbert talking about availability and effectiveness of peer services in diverse setting. It's a great webinar. We have great, very committed research scientists being speakers on this webinar. So we invite you to register. We're sharing the link with you all. This one is the first one on Friday, December the 12th. We'll see you there. Next. And we're having our Texas session. This is going to take place on December 16 at 12. We're having an expert. I'm sure that some of you already have heard of him. His name is Terry Scugging, and he is a specialist in access to health in rural settings. That's going to be our Texas session. As you all know, we have these sessions as a precursor before our Texas Substance Use Symposium. So Tuesday, December the 16th, we're sharing the link with all of you. Please don't miss it. And you may find more information about Texas as well on the website we're sharing with you. That's texas.org/sessions. Next. And we're officially open for presentations. We're opening this call for presentations to those who are in the field of substance use disorders, whether they are researchers, behavioral health professionals, peers, anyone in the field of substance use disorders who would like to share information or new discoveries here at the Texas Substance Use Symposium, March 2 and 3. So we're sharing the link right now. Again, we are open for presentations, proposals for presentation. We would love for you to join us. Please join us in advancing substance use education, innovation, and recovery across Texas. Next. And of course, we're not meeting in December. We're not having behavioral health echoes in December, of course, for the holidays, but for sure, we're going to see you all here in this space on Friday, January 30th, 2026. Thank you. And I think we can start sharing the case form. And Joseph, if you don't mind, you could briefly walk us through the most important aspects of this case. Thank you.
All right, guys. I'm here. I'm just listening. So on this case that I wanted to bring to the table or to this group to look at was also going with the dual diagnosis of, the mental health and also the substance use disorder part. So on this case, it's going to be a 41-year-old female, white female, straight. And some of the questions that I'd like to address during this session or some help on is how we can continue to provide effective support for that participant that's taking naloxone, buprenorphine, and what forms of stigma might she encounter during this being on that medication, and the continuing support on her own sobriety while maintaining the care for her children who are also in recovery as well. So in this case, I have a participant that I've had her for about I wouldn't lie to you guys. I've known her for about more than 5 years. So as you know, anybody that's in recovery, it's not just a 12-month process. It's going to be a process that takes longer. I've been a person in long-term recovery for 17 years, also in mental health recovery as well. So for this, I've known her for more than 5 years, taking the opportunity to help her along the way. And some of these things that she's gone is being overwhelmed because her children as well, getting into trouble in school, being suspended. They are part of the YRC program, which is the Youth Recovery Communities program, which is having recovery coaches for children from the ages of 13 to 21. So they have a recovery coach as well. She's involved in that aspect. And when it comes to her, we're involved in her recovery. So some of the things that are concerning for her that she's gets overwhelmed and sometimes does and has also, stated that thoughts of, suicide because of being overwhelmed, because of so much that she feels that is going on in her life that she takes fault for, I guess, the way the children act. She does come from a two-parent home. They do have a trucking company as well. So we've tried to, I think one of the biggest things that, and I think that I was listening to Elisa when she was in Spain, is one of the biggest things for people in recovery from mental health or substance abuse is having that open communication with anybody that's willing to listen. I think that's one of the biggest things because a lot of people do not open up because they feel that they're going to be judged. There's that stigma. Me and my personal for, my mental health, I didn't open up for many years. Why? Because I didn't want people to think differently of me. But I prefer, and I tell them, I use myself as an example. We need to talk about different things. I'm not here to diagnose you. It's just a simple conversation. And that is what sometimes is what a lot of us just need. So with her being with the issues at hand that I've mentioned, some of her goals are just to continue with, I had mentioned, they do have a family trucking business. She wants to continue with her sobriety because she's been sober for 12 years now. A personal goal was to lose weight, continue her education, get back into college, and have more engagement with peers. She's one of those that is very, very willing to, Joe, do you have an event? Would you allow me to go talk to your clients? Would you allow me to talk to them about, my mental health journey, my journey in substance abuse? All of that. She's actually been a part of our YouTube channel as well. So, I mean, she's really involved because she feels that this is the need and this is what helps her. So, some of the biggest things that I've seen that helps her in her pathway is going to be that she does have a very good support system with her family, and of course, not with just one recovery coach. It's about four of us, four different recovery coaches. Why? Because you have to have a circle of support. It's not just one person. So she has communication with a lot of, so she does use those very well. She does have recovery coaches as well for her children, from in the YRC program. She's very involved with those. They do a lot of events for these kiddos. I think they had one yesterday. I just saw it pop up on the social media. They have dinners for them. They have movie nights for them. And what's crazy and pretty cool that I've gone to the YRC facility that we have here. They have arcades there. So if I ever find to be lost, that's where I'll be because it's pretty cool. They have a pool table. They have arcade games there. They have a bunch of stuff. They have the PS5 there, PS4. So these kids have it's a great area where they are able to hang out and they hang out with the recovery coaches. That's how they build that rapport with them. So that's one of the biggest things. I think those are one of those biggest strengths that she has and the resources that they have there in that with this YRC program. So so some of the biggest things that we've learned along the way that she's learned as well is going to be how we can the different things that we've tried is going to be positive self-talk. One of the biggest things that I've learned in helping others is having positive self-talk. If you have to be your own cheerleader. So you have to kind of tell yourself, this is where I'm at now, where I'm not, where I haven't been, this is what I'm doing. And you continue to positively talk to yourself and get back up motivated. There's also been face-to-face sessions with this female. And we also have done and concluded and done some home visits as we are allowed to. If we don't visit them at home and they feel better, we can visit them in the community. I've gone with people that have been through, maybe they're going through a break, they're going through maybe some situations where I just don't feel good, I don't feel right, I just feel I need. Hey, well, where you at? Let's meet up in a park, in a public place, and let me go buy you a coffee. Let's just go sit down and talk. Let's just do something where they feel that they need to be heard. Because, like I said, as a person that also struggles with mental health, sometimes I just need to be heard. You might not even have to tell me anything. Just listen to me. Just sit there, listen to me, and maybe this is all I just need to get off my chest. Because that's like I said, all of us are very different. All of us are very different on how exactly it makes this, I guess, feel better at what we're doing. So it's like I said, we take it one day at a time. So some of the things for her in, I guess, going back into her life and story of the current use of her substance use and everything. So some of the things that we would ask her, stimulant use, no. Nicotine, she is a daily smoker. She's been smoking for about 20 years. Alcohol, she does not drink. Cannabis, she does not smoke. Her drug of choice was opioids, so it was heroin, which was for about 2 years. And more questions that we've asked when I was able to talk to her was, counseling for substance abuse. Of course, she's done it in the past. She continues to do it in the present because being in medication assisted treatment, they do still have counseling and everything. Inpatient, she had been inpatient before. Not currently, not recently, but in the past before. The mutual aid, the smart recovery, no, and present in the past, nothing. So at the moment, she is on buprenorphine naloxone, which is, I guess, Suboxone. So that is what she's currently using for her recovery for her substance use disorder. She doesn't report any mental health. She would like to get her assessments done. So we look in the community for what is available for them. We do referrals for our local mental health authorities to get them into what they would need. But she does also state that she has. Oh, and I guess from looking at the notes back that I'm looking at now, when she wasn't inpatient, she did inpatient treatment twice. I remember she told me one time she didn't make it because she had gotten into some trouble there, but she did get this discharge successfully one of those times. Last time she was in a residential treatment was more than 10 years ago. She does has stated that she does suffer from, not suffer, I don't like using that word suffer, that she does struggle with depression, struggles with anxiety, and also ADHD. So a lot of this can come from the history of what she's been through. And you know that sometimes it's really hard for people to open up and especially give some information on why or what they've been through. And with her, she was molested by a family member from the sixth grade to ninth grade. She was in an unhealthy and a very physically abusive relationship for about 5 years as an adult. She couldn't get away. We've talked about it, and of course, she's made it. She's been out, but of course, all of that is going to still kind of hold something on you. But like I said, a lot of things can be through therapy, through counseling, that are going to get you through those motions to get going. And sometimes they go back on that part. So her being involved in anything with the criminal justice system at the time, nothing. She's been out of she was successfully discharged from any type of probation back 10 years ago. So as I mentioned earlier, she is on Loxone 18 milligrams a day, prescribed by her medical doctor for MOUD. And going through the notes that we have here listed, the behavioral health therapies, she's engaged, motivational interviewing, not the CBT, the consistent management, harm reduction services always there because of MOUD, peer recovery support services, which is us, recovery coaching, Also, the acceptance community therapy that she goes through with counseling. She does also do recovery groups, peer groups with us as well. But like I said, it's a lot of she's looking for a lot of different things to continue. She knows where she's at, she knows what she needs, and the good thing with her is she's specified in a lot of I know where I'm at, but it's like anybody, you know where you're at, but you want to continue and you want to continue with that kind of support that you need, just like I continue with my support. And I always put myself out there because I tell her I do the same. You know, I still continue with recovery groups for myself, where I'm not the presenter, but I'm an attendee. You know, I do my NA. I also speak to people that are mental health peer specialists as well for myself because I need to continue with my journey as well. So this is the case I have presented for today. This is where the notes have done. It's been a while I haven't done this, guys. So if I'm a little uh, on the bad side, don't judge me there. But I try, But like I said, I try to give you guys as much information as I could. And like I said, I'm really all for these case presentations. Why? Just because it gives me a time and an opportunity to really look at a case more in depth and present it to others that have no idea what I'm talking about because they don't work with this person, but to get feedback. And so they understand where I'm coming from, what I maybe could do, and any kind of suggestions. So I'm all open to any of those questions that you all may have.
Thank you, Joseph. You did great. This was a very interesting case. Someone here, Dr. Lugner, has a question. Dr. Lugner, would you like to unmute yourself?
So what my question is, has she had previous suicide attempts, or has she had these kinds of feelings of suicide in the past?
To my understanding, there hasn't been attempts. There might be the ideas, or maybe just the voicing out, but no attempts, no plans, from my knowledge.
Okay. And then how comfortable do you feel talking to her about this topic? I know as a healthcare provider, sometimes it's comfortable asking questions, and sometimes it's not very comfortable asking questions. It's kind of a countertransference going on. How do you feel when you're talking to her about that?
Regarding like the suicide,
Suicide, yeah.
I'm comfortable. Why? Because I understand it, and like I've shared with you all, and I don't like to minimize what I've been through, but I've attempted um suicide twice in my life. I've gone through a plan and didn't go through at the very end, but the attempt was made. So I understand what it feels like. I understand how it can affect someone, but I've learned throughout these years on how to have a coping communication with people that understand it, that won't judge you because you're just a coward. You just man up. So I understand people. I understand you have feelings, and especially as a man, because you understand that as men we're supposed to, I don't know, that stigma of you're not supposed to feel a certain type of way. It's like, man, no, I'm not my dad. My dad was really is still a person that it's another topic that it's just I can't go to him for these kind of questions. It's just man up. That's all you get.
And
So
my final question is on the CBT. Is there any opportunity for her to get CBT? I noticed that was not one of the
oh
things
yeah,
she
of
was.
course, yeah, there is, and that's just something that we just recently touched based on. So that's our next step. That's the next resource that we're going to look into. But that is something that yeah we're looking into.
Thank you. That's a very good case.
Thank you.
You don't need that?
Yes, thank you, Dr. Lugner. I want to say we are trying to upload some material in the chat related to everything that we have been talking about. I understand also that there are certain type of files that we cannot upload, but Leslie, you may try now to see if it's possible for you to upload some of the materials that no, you can't. Okay, so it's probably a limitation from our Zoom call, but it's okay. Lindsay, do you want to say something? Please go ahead.
Yeah. So it sounds like you're doing a really good job. And I'm not sure if you said the name of the youth center, but that sounds awesome. I'd love to know what center that is. And then as for maybe suggestions, I know that like for myself, I'm really interested in EMDR, the eye movement desensitization reprocessing, I believe it's called. But it's for trauma specifically, and I've heard really good things about it.
Yeah, so the facility that I was talking about it's well, it's the name of it's a YRC. It's the that's the way the contract has it. It's youth recovery communities. So, I work for the organization of Aliviani here in El Paso, Texas. So that's one of our programs we have under the organization. And that specifically holds recovery coaching, case management for peers from the ages of 13 up to 21 years of age. So that's something new that came up a couple years ago, and it's actually pretty good because they work a lot with JPD, so which is Juvenile Probation Department. JPD, especially a lot with truancy. These kids nowadays think that they don't need to go to school, so they get in trouble for it, and that is where we come into play and try to, give them a little bit of understanding of the schooling and what it can cause, and trying to get them out of certain groups. And we can only try so much because, like I said, it all depends on the person. But that's the idea that we're trying to do, is the purpose of trying to get some good information in them so they can make those best decisions for themselves.
That's great, Joseph. Leslie.
Yeah, I agree with what everybody is saying. I would encourage, as others have said, is to consider some CBT as well. There is the brief CBT for suicidality, and it actually does include trauma-focused support and also substance use recognition. So it's really good for individuals that have those different experiences that they're trying to really target. I'm also an EMDR provider and am able to do that with kids and pediatrics. EMDR does not have the highest level of effectiveness with PTSD, and it actually just went down on the evidence list. Although I have to say I've seen great outcomes from it. It is CBT based. And so starting the CBT would probably be a really great recommendation. And then if the individual continues to have some of the symptomatology, then looking at something like that, which kind of has more of the PCT experiential pieces, either going to one of those or an EMDR if someone is interested. But just making sure that clarity too, now that it does have a level down as far as its evidence.
Thank you. Didi, you wanted to ask something? You said
Sorry, just
something.
typing. I'm also
Yes.
certified in brain spotting, and brain spotting is kind of an offshoot of EMDR developed by someone who was one of the big trainers in EMDR, and it works a little bit longer, more effective, and a little faster. But not everything is right for everybody. I use it in my practice, and some people do great with it, and other people are like, "What is this?" So, and that's fine. Totally agree with the CBT, and also perhaps something like some mindfulness-based relapse prevention might be helpful as well. My questions were about there was a mention of some stigma around her use of medications, and we were all kind of curious about where that might be coming from at this point. It seems like she's been on the medication for a while. She's not attending any mutual aid group. So is it coming from family, maybe from herself? Do you know, Joseph?
You know what? Honestly, I don't want to lie to you. I don't know because I haven't we haven't. There's a lot of, when it comes to like different cases, like there's so many questions. Like this question, I'm like,
Yeah.
what? I've never even mentioned or gotten to that topic because there's so much. I've talked to her for a lot though. I've talked to her for many years, and there's certain things that maybe I don't know. Like Doctor, like Ralph had said, there's some questions that maybe I just haven't asked because I maybe not felt the way to ask, or maybe I feel I'm
We
not
can't ask them all,
good at.
Joseph.
Yeah. So, but those are valid points, honestly.
Yeah. We were, again, just curious about that. Yeah.
Oh, thank you. Yeah, but
Yeah.
thank you.
Thank you, Joseph. And we're almost at the end of the hour, so I'm going to ask Elisa after that great presentation that she gave also, she could give us some, like a little summary of some of the alternatives that have been discussed today for Joseph, for our case present.
Absolutely. Thank you, Joseph, for sharing. And in summary, we talked a little bit about maybe continuing to facilitate that open dialogue that you have with your client, assessing for suicidality, maybe developing a crisis response plan, maybe even doing some CBT for suicidality that can help with trauma and substance use, and maybe learning a little bit more about what is pushing that current stigma or what's kind of honing in on that. And then lastly, maybe assessing for PTSD symptoms, possibly engaging her in an evidence-based treatment such as EMDR, and I'm going to slide in CPT.
Yeah, I know that CBT is, I think, the biggest one I've heard today. So I'm be looking into that one for sure because that's seems like it's something that works, right?
All right. Well, this has been a great conversation. And like always, it seems like the time goes too fast. But we'll see you all in January. So to all of you, happy Thanksgiving, happy holidays. We'll see you next year. And thank you from here, the team at CSTAT, for supporting these sessions. We'll see you soon. Thank you. Bye.
Thank you guys.